introduce, you know, the students always laugh because I always call you and Pat McKeon. So McKeon, you know, we'll get it right. Jennifer McKeon. You can see all the different titles that she has behind her name. Jen came here in 2007, is that right?
Yeah.
7? So she's been here a few years, and she came via postdoc at Chapel Hill, is that correct? And help me out with undergrad and doctorate.
Penn State, the Arizona School of Health Sciences, which is now ATC University. Back to Penn State to work clinically for a while as an athletic trainer, and then after that started into my PhD at Penn State. Technically finished my PhD at Penn State, but did my dissertation at UVA. And so my advisor left, he went to UVA, and then so I went down there, followed him down there, but my degree is from Penn State. So.
Well, like I said, I think if you don't know Dr. McKeon, perhaps you know her husband, Pat McKeon. She's also, you know, mother of the famous Bobby McKeon. And I just got sort of a bombshell. Jen said everything's going really great and wonderful, and her and Pat are actually leaving the University of Kentucky. So we're very sad to hear about that. Hopefully maybe we can have you guys come back.
Oh yeah,
From
awesome.
Ithaca and have you present on future findings. Jen is really a link. She is very involved in multidisciplinary work, and she really links the researchers with the clinicians. Emphasis in athletic training, injury, and biomechanical analysis. Is that a fair summary?
Yep.
Okay, well, without further ado.
All right, thanks, Jody. Yeah, so I think that those are a couple of keys. One, I take a multi-modal approach to the different types of research. I've done some biomechanics, some epidemiology, I do a lot of systematic review, critical analysis of literature. I want to do a bit of everything. And so, but one of the biggest things that I find kind of frustrating with research all over is that with research in general, we've got this big gap. We've got these awesome biomechanical studies, and I'm going to speak mostly about athletic training stuff, so injuries that happen to athletes and that type of thing. But we've got these awesome biomechanical, sensory motor, neuromuscular, some genetic. We've got all these awesome studies, but the problem, and if you go and you talk to clinicians, is that there's a gap. That those studies, while they're important and very, very good, they don't necessarily get to the clinician. So my professional goal and my research goal is to bridge that gap between what happens in the lab and what gets out and is useful and feasible for the clinician to do. So things like 3D motion analysis, force plates, you know, analyzing the literature on your own, all those types of things. Those are all things that sound really good and answer questions, but when you say, hey clinician, you know, I want you to do some 3D motion analysis on all your athletes to find about risk factors for ACL injury, how are they ever going to be able to do that in a feasible and in a cost-effective and time-effective manner? And so I want to be able to generate some clinically useful, valid tools in order that clinicians can actually use that link back into the research that is being done in the labs. And so I use this three-pronged approach of using an epidemiological approach to describe the injury problems and generate some prognostic information. I'll also do some systematic reviews and meta-analysis of the literature, critical analysis of literature, and then also trying to develop some specific clinically relevant, clinically meaningful tools for injury risk factor analysis. So this is where I sort of spread myself a little bit in these different directions, and I'm going to talk about each of these different areas here. So the first one I'm going to talk about is generating clinically relevant, useful, and valid prognostic tests to identify risk factors for lower extremity sports injuries, and I'm going to mostly relate this back to the ACL. One of the most significant risk factors for injury is previous history of injury. And when we think about the long-term consequences of musculoskeletal injuries, we're thinking about predominantly osteoarthritis, but also things like decreased physical activity, which then leads down the trail of obesity and decreased type 2 diabetes and all those bad things that happen when you're sitting around all the time. My big soapbox, and I was an athlete, I was a D1 soccer player at Penn State, and we were top 10 back then, and they are continuing in the top levels right now. But while I was in high school and then also in college, I had 2 ACL tears, a meniscal and a avulsion fracture in my knee, so those were 3 knee surgeries. Sprained my ankles, I don't know how many times. I've dislocated the shoulder twice, had 2 repairs on it. I've dislocated this shoulder. I've torn my triangular fiber cartilage in my wrist, like lots and lots and lots of injuries. The problem with it is that the sports medicine team, while they're really, really good, and this includes athletic trainers, we only focus on the short term. And I mean short term as far as even a year out. So the poor kid that just broke his leg so bad in Louisville, they're already talking about, well, he'll be back in a year, he'll be back in a year. But that's still short term. And what are the long-term consequences? And the problem is that when you're talking about the people in playing sports and in a 4-year institution, things like that, it's a very short period of time. And we, the clinicians, only see them for a short period of time, and then they're gone. And they're usually gone forever, and we'll never see them again. And so we've really got to do a much better job at thinking about those long-term consequences and preventing those injuries so that down the road we don't have to hear about things like you hear about now with all the concussions and the depression and things like that too. The other thing is that within the NATA, the role delineation study, so for athletic trainers, our first domain is prevention. But I always ask, what the heck are we preventing? Injuries still happen and we don't prevent very many of them. The real problem with prevention is real risk factors are hard to identify. And usually because injury risk is very multifactorial. There's not one factor that's going to say, yeah, this is going to increase injury risk. And the other thing is that looking for risk factors is not very cost effective. First of all, there's not very many injuries that happen, so it's really hard to prospectively analyze for risk factors. But also, is it worth it to test for certain things, and how much time does it take? So that comes back to the 3D motion analysis. Yep, predictive, it looks like some of the 3D motion analysis, force plate analysis, and things like that can somewhat predict ACL tears. But you know that it takes, and probably a lot of you have at least done some motion analysis, it's going to take a minimum of 30 or 45 minutes to test one person, and that doesn't even count all the setup that you do before that person even gets there. How are you going to effectively test maybe 50, 20, 50, 100 athletes, maybe 200 athletes all at your school? So we need cost-effective but also time-sensitive tests that can be done quickly and cheaply, and they're also easy to analyze for the clinician. So just to give a little bit of background, this is the Kentucky High School Athletic Association. This is one page of the physical exam, the pre-participation exam. And I know it's small and you're not meant to really look at it, but it's got all these things in here as far as body parts, and just abnormal, normal, abnormal, and then some comment. And all the kids go through this, and you say, great, they all do this pre-participation exam. And probably some of it's important, the lungs and the eye stuff, that's probably important, but when you get down to the musculoskeletal, I'd like to know what they're testing for that's going to be predictive of somebody who's at risk for injury. And the truth is, we're testing the wrong thing. So research labs are too costly, clinical tests are not very specific or predictive for musculoskeletal injury, so that's kind of where I was stepping in with some of the stuff that I've been doing. So, specifically with the knee, and this is, like I said, I'm going to talk about ACL injuries a lot for this one. ACL injuries are costly. They also lead to time loss from participation. They also lead to OA in the long term. And one particular risk factor has been identified, and it's this 8 degrees of knee abduction. And there was a couple other risk factors, but ones that actually seem to lead people to an increased risk for ACL injuries, and that's increased knee abduction while doing a drop landing task. Problem is, again, that was found during 3D motion analysis, this 8 degrees of knee abduction, which is expensive. So how do we bring the clinician to the lab? And this was one of my funded studies. And this was the purpose of this study was to develop a cost-effective and efficient mechanism using 3 phases of a study to develop a method using 2D motion analysis, which is really just video cameras that I bought at Best Buy. So the first part was the validation part. So we took 33 high school athletes and we had them do a drop vertical jump and a single leg jump, and we concurrently analyzed them doing these jumps using 2D motion analysis and 3D motion analysis to look at their knee abduction angle during this drop landing. And that's really what we're looking for, is the change in the distance between their knees. On 2D, in 3D, we actually get that real abduction angle that change during the processing. As far as what we've found, it's not a perfect, the problem with this is that it's not going to be perfectly valid, because we know that this isn't just straight up knee abduction. We know that there's in this picture here, we've got a combination of abduction, we've got a combination of hip internal rotation, we've also got hip adduction, we also got you even get some knee flexion in this measure. So as far as a true validity, we're not really looking for true validity, but we're looking for some sort of correlation between the two. Can we somewhat correlate what happens here to what happens in real time? And it's not too bad. I mean, right now we've got all the data collected and post-processed. It's not an awesome correlation, but at least we're working towards seeing how we can improve it. And maybe it's not directly at that 8 degrees, but we might be able to do some combination of the analysis between this one and this one. So we're going to see. We're not really far on this one quite yet, but we're going to see how this goes once we analyze a little bit more of the data. The other thing that we want to look at for the 2D was the intra-rater and inter-rater reliabilities. So we took the 2D motion analysis. We had we used that 8 degrees of abduction to classify people at high risk or low risk using 3D. And then we said, can we show these videos, the 2D videos, to certified athletic trainers and have them classify high risk or low risk just based on those 2D videos? Can we do that? And how reliable would they be over time? So we had all the athletic trainers watch those videos, and every single video that came by, they'd write down high risk or low risk just based on how the person landed. What we saw here was they were actually awesome. They were very, very reliable. And so across time, that our kappa statistic was about 0.8. So over time, the ATs were very, very reliable. So we said, cool, it's reliable. They can look at the videos and reliably say who's at high risk and low risk. So we said, okay, what about compared to each other? So let's do some inter-rater reliability. And if they can watch those videos, are they rating people the same as their colleagues there? And they were. Again, the kappa statistic was again at about 2.8. So we said, cool, the inter-tester reliability was really good. Next, we did diagnostic accuracy. So we used that 8 degrees of abduction as the gold standard of high risk versus low risk. And then we said, okay, how are their ratings comparing to the gold standard? And then that's where we ran into trouble. What we saw here was our sensitivity and our specificity was like 65%, which isn't that good when you're talking about true diagnostic accuracy. They weren't rating the videos the same as what the 3D motion analysis, what we were rating them with 3D. A couple of things with that, though, is that, and if you don't know for sure, but from a sensitivity and specificity standpoint, 50% is considered a coin flip. So we're slightly better than a coin flip here. Now, a couple things. We're slightly better than a coin flip. We're above 50. We're not obviously anywhere near 100%. But still, if I'm thinking about a screening tool, something that I can do really, really fast and just pick somebody quickly, maybe 60-65% is not that bad. To give you an example, I had strep throat in the fall. And have you guys had strep throat before? Everybody's had. So what do you do when you get strep throat? What's the test? They swab, right? They swab and then they put it in a petri dish. And then there's two things they can do with it. They can do the quick screen, which gives you an answer in like 10 minutes. Or they can do like the full test where they grow the culture and 2 days later you find out you have strep, you go get your penicillin. So when I had strep the other day, and I didn't even know they were doing that. I had strep, or not the other day, last semester, and they said, all right, we'll be back with your results in 10 minutes. And I was like, what? You can grow it that fast now? That's crazy. And so they came back and they said, no, you don't have strep. That was a screen. And actually that was a false negative. I did have strep, and I had to go back a couple days later, and I had to get penicillin anyway. So the screen was wrong. So that was a false negative. So screens aren't as good as the gold standard. That's kind of the problem with them. But the other thing that I thought was good though, the specificity, which was 0.65, 65%, was a little bit higher, and it gave too many false positives. Now from a screening tool, false negatives tend to be bad because you lose people that really have the condition of interest. In this case, they lost me and I had strep. But in this case, where you say too many false positives, all right, I would classify too many people as high risk, and I would intervene on them. Well, that's better than classifying as false negatives and not intervening on them. So 0.65, all right, from a screening perspective, I add a few more people to my intervention injury prevention program than I should have. All right, maybe that's not too bad. We're not, we're still looking into this. We're actually rerunning this study again to see if we can give a little bit better direction to the ATs. And see if the scores come out a little bit better, but we don't know that yet. But the other thing is, between the inter-tester and intra-tester reliability, the thing that I think is awesome is that from a machine standpoint, the 3D motion analysis, they're not seeing what the 3D motion analysis is seeing. But as clinicians, they're all seeing something reliably. And maybe it's just not being picked up very well. What they're seeing is really important, and it's not being picked up very well by the machines. So that's why we're still continuing to investigate it, even though I was a little discouraged by, those numbers initially. But that's why we're just still going with it. Okay. Talk about that. Currently, what we're doing, we're also doing stability over time and responsiveness to change. So we took all of those cameras out to the gymnasiums, high schools in the area. Because that's really where you're going to capture these things. You're not going to be able to bring a whole bunch of kids from all over Kentucky into a lab. We had 2 basketball teams that served as controls and 2 that served as the intervention group, did an injury prevention program over the course of an entire season. And so we had predominantly what I'm going to talk about here is that measure of 2D, that stability over time. So if we look at them doing a drop landing in the beginning of the season, does it look the same at the end of the season? And if there's an intervention, does it change? I can tell you about this part here, it didn't change. So that was cool. Like, it's not even just an inter-session reliability across 2 weeks, but across an entire basketball season, the girls were doing about the same thing at the end as they were at the beginning. So I was really encouraged by that at least from a stability measure, we're looking pretty good. We've got the data on this, we haven't gotten a chance to analyze if the intervention worked. I'm a little bit questionable, not because of the 2D measure, I'm actually more questionable on how they did the intervention. Even though we had an AT going out there every week to help them through it and everything, their compliance, I think, was a little questionable. So, but we'll see what happens with this one as we analyze a little further. Oh, these were the stabilities. Sorry, I forgot that I put the slide in here. But these were the actual stabilities. From the lateral is 0.92, and then from even the anterior 0.7 to 0.85 with that really funny, coming together at the knees and everything, which is sort of a funny view from the anterior because you're not getting pure knee abduction, and you're getting that combination with hip internal rotation. It still was fairly stable. So we were really encouraged by these measures overall. Those are just some papers we're putting together. So in summary, we really do have to tie some of the traditional biomechanics to something that's a little bit more clinical. And that's what I really am hoping that, as some of you guys, if you're doing your theses or your dissertations and things, think about ways that you can either work with clinicians, or if you are a clinician, to take what other people are doing in the lab and start to transfer it out to people that are going to be using it, because that'll help to bridge that gap. So I'm going to move on to the next step. And I know I'm going a little fast, but I actually have to sprint out of here right at the end of the thing. I've got a thesis defense student defending today, so I got to run. But the next part is an epidemiological area. So I've done this biomechanical stuff, but now I'm using epidemiology. And it's looking at this idea of when my athlete will return to play. That's the primary question that people ask when they get hurt, or what coach is going to ask. After they say, okay, are they going to come back? Are they okay? You know, are they going to, you know, is their leg or whatever going to be fine? When are they coming back? And so this is really getting into prognosis. And so I'm using an epidemiological approach to make better prognoses, to provide some objective evidence. So I'm going to talk about ankle sprains for this one. I talked mostly about knee before, now I'm going to talk about ankle sprains. If you look at ankle sprain timelines, ligaments heal 6 to 12 weeks. So for full scar maturation, all that thing. But when you talk about ankle sprains, most people return in less than a week. The average is like 3 days or something like that. But then if you look at the medians and things, more than 50% return at 1 week. So that means that athletes are routinely being returned to play prior to the tissue being healed. So as far as saying when the athlete's going to come back to play, tissue damage is not, in isolation, is not a good prognosticator. And the other thing, so we need some other objective evidence to think about that. Now, most of our return to play timelines come from anecdotal information from the clinician. They take a look at it and say, well, you know, based on my anecdotal experience, this is when that person is going to come back. And that's okay. That's not wrong. But some objective evidence has to be provided too. So when we look at prognostic indicators, we can look at the course of events, so things like swelling, inflammation, specific to the injury or around the injury. We can look at you know, pain. We can look at kind of the other indicators, signs and symptoms. But we can also look at a timeline of when those events occur. So what I'm using for this is what's called time of event probabilities. It's the same exact thing as survival probabilities. So survival probabilities are just, if you have ever thought about them as far as what they've been used for in the past, usually for life-threatening conditions. So I get told I have cancer. Okay, doc, what's the chances I'm going to be alive in 3 months? Oh, chances you're going to be alive in 3 months are like 90%. How about my chances in 3 years? Ooh, that's going to be like 2%. Okay? So now I have an idea of what my survival timeline is going to be, the probability of when I'm going to die is going to be. So I'm using the exact same thing. We've not used survival probabilities as far as in the athletic population for looking at return to play. So I'm not looking for when athletes are going to die. I'm looking at the probability of when they're going to get back to play. So even though it's called survival, really I'm just looking for when that event's going to occur and when that event is returning to play. Now, we can look at prognostic information other ways. We can look at things that are versus, like, for example, proportions. We can say, well, in the past, 8 out of 10 of my athletes returned after 3 days. Well, that's great. So if we look at this little table, and I know it's small, but, you know, if we just look at when athletes are returning, we don't get a very clear idea. So these could be ankle sprains. Well, 26 return the same day. But 11% return the next day. But 30% return in 3 to 6 days. 11% return. What do you make of that? You know, what's the percentage that somebody's going to return to play? This doesn't make a lot of sense. The other thing that we can think about is taking on average. All right, so we can take the average, but if you say, well, this is less than 1 week, most people return in less than 1 week or greater than 3 weeks. Well, the average falls here, but does that give you a good probability of when somebody's going to return? No, that's the average, but it's obviously misleading. The last thing is that both of these types of analyses throw out what are called censored cases. And censored cases are the ones who don't experience the event in the timeline that you're studying. Basically, for sports, those are athletes who don't return before the season's over. And with the time to event probabilities or survival analysis, time to event analysis, you include those people who don't return as part of the analysis. It goes into the math of it. So what I want to do for this particular project, I want to know when an athlete was likely to return following an ankle sprain. So I'm going to generate some statistical estimates of when people are going to return after an ankle sprain, but then also look at how injury history. If you have a new ankle sprain versus a recurrent ankle sprain, are those timelines the same? So we used injured high school athletes, who are still studying the high school athletes for this particular study. Ones that got ankle sprains, and this in particular is about lateral ankle sprains. So the most common ones where you kind of twist your foot, you turn it in, and you get an inversion sprain. So I was looking at the most common ankle sprains. And we're looking at particularly new injuries, which were brand new, never had a sprain before in their life, versus recurrent, where the recurrent ones where they had a sprain on that same ankle at least once before. And then we determined injury severity based on how much time that they lost from participation. All that got entered into what's called a Kaplan-Meier survival or time event estimator. And then we generated a curve on this, which I'll show you, and then we compared the two curves, new versus recurrent, using a log rank test. So across the 2 years, there was 201 ankle sprains, 164 new, and 37 recurring. For both new and recurrent sprains, the median time to return to play was 3 days, with a range of, interquartile range of next day return to 7-day return. So basically that supports all literature. People all go back in a week, or a good share of them go back in a week. The other thing is that there was no significant difference between the new and recurrent ankle sprains as far as time to return to play. This is a table, and I just want you to focus really on these boxes here. This is the probability of return to play. And what you'd see is, and this is how you'd read this, you've got your time points over here, same day, next day, 3 day, and this is for new ankle sprains, this is for recurrent ankle sprains. And what you look up over here is that for a same-day return, it's about a 23% chance of return. But if I jump down to a 3-day return, it goes to 72%. Within a 10-day return, 94%, 95%. So within 10 days, almost 100% chance of return. And actually, even though they're slightly different, it was not significant. So if you look at recurrent ankle sprain, same-day return approaching 20%, 70% for a 3-day, 95% for a 10-day. So what's the utility of this? If I'm an AT and coach says, and it's a 3-day tournament, coach said we're on Friday, best kid sprains his ankle. What is the probability he's coming back today? It's halftime. 20% chance of returning. I wouldn't count on that kid for today. Let me treat him, let me sit him down, let me just take care of this. Well, how about tomorrow? Well, tomorrow it's going to jump to almost 50%, 40-50% chance of return. We can start to consider it. But if we wait till finals on Sunday, there's like a 75% chance. If you don't need him for practice on Saturday or for the game before run around, pregame run around, or anything like that, let me treat him one more day, and then on Sunday when it's the finals, there's a good chance that person's going to be ready, and I'll have a little bit more time to treat that person. Is it perfect? No, and you got to negotiate a little bit of that, and also you got to look at how bad all the signs and symptoms are and how that person's doing, of course. But it provides some objective evidence, at least to provide to the coach. Yeah.
Is this all for no grading, say, of like different ligament sprains? So you're taking them all together?
This is with no grading, yeah.
Okay.
But actually, we did. It's not for ACSM, it's for NATAs. I think we're presenting on ligaments for NATAs. We did do it based on ligaments. We did it for a much bigger sample from the high school Rio database, which is huge. And we did do it by ligament. And there was a difference based on the number of ligaments damaged, which is, there's like probably 13 grading scales for ankle sprains as far as how to grade severity. So just one of it is based on the number of ligaments damaged. But a grade 1, meaning a single ligament ATF injury versus a grade 2 ligament and a grade 3 ligament, there was a significant difference where the grade 1s and 2s were fairly close to each other as far as their curves, but the grade 3s were substantially longer. So that was kind of cool. Yeah.
So you could really, you could really improve, say once you've had a chance to go in and diagnose it, right? You calculate which ligaments are damaged, then you could give a better probability estimate to the coach.
Yeah. Absolutely.
Sex differences?
No. And for ankle sprains, I ran them by sport, sex, age, BMI, year in school, level of play. I don't even remember. Nothing, which was really interesting because, well, for ankle sprains, you know, it's kind of 50-50 in literature. Half literature says, yeah, there's a difference between males and females, and a lot of literature says there isn't. So, no, not even close. And I ran ankle sprains by about everything I could find. Ligaments was the only ligament, the number of ligaments damaged was the only thing I could eventually find.
Were you able to account at all for the type of treatment they received post-injury? Because that's got to, I mean, that certainly has to happen.
Absolutely, and no, not for this one. So, a couple of things that are tricky. So, for the really big databases like High School Rio and then also the NCAA, which I'm going to be analyzing, I've got that database and in the process of analyzing some of that right now. Treatment's not included in there, so definitely something. The other thing, but the problem with those two databases is you can't look at recurrent injuries. So in our database, you can look at recurrent injuries because we actually had a single number for each subject. But with doing survival analysis, you have to know if one person had 5 recurrent injuries or that was 5 people with 1 recurrent injury. And in NCAA High School Rio, you can't track that. So in those two, you can only look at new injuries. Now, getting at the intervention stuff, none of the databases in those have interventions, but we are going to analyze some data from West Point, which does have interventions, and we're going to classify it based on, loosely. So we'll, kind of take strength as one type of intervention. I don't care if they did tubing or TheraBand or cuff weights or whatever they did, towel exercise, manual resistance, I don't care. But I would just call that strengthening, and I would have one section on pain management, whether that was, ice or if that was stim, all right, pain management, pain control, and so kind of block them into 6 or 7 areas of intervention. So that's the next step, because that's a cool thing is that this can be improved by a lot, but at the same time the evidence isn't out there, so it's like, well, kind of starting from scratch. So yeah, that's going to be another step coming along the way. This was our actual survival curve. So starting at 100% here of same day return, it drops off, and then you can see what the main thing to look at here is that you've got new injuries in black, recurrent injuries in dotted, and you can see those 2 curves almost lay right on top of each other. And so there's no substantial difference between those 2 curves. If we saw one curve that kind of went out here like that, while the other one went down here, we'd say, oh yeah, those curves are different. But those curves are pretty much exactly the same. So no difference in return play between new and recurring. So, it's interesting because there's such a short return to play timeline for ankle sprains compared to, let's say, MCL sprains, knee injuries. And it's, if you take an MCL sprain, and I took that one mild to moderate, MCL sprains tend to be restricted anywhere from 2 to 8 weeks. And if you think about it, it's still a ligament, still a lateral ligament even, or a collateral ligament, I should say, that the lateral ankle or the medial knee, I mean, those are collateral ligaments for the joint. But it's just kind of interesting, the perceived disability associated with the knee is far worse than the perceived disability with the ankle. And I think one of the key things to think about is that probably a more conservative return to play consideration for ankles is warranted because you've got ankle sprains being the most recurrent injury in musculoskeletal injury, up to 70% are recurrent and or become recurrent. But I think this really gets at this part of this survival analysis is getting at time-based prognostics. So if we take this kind of 3-pronged approach of patient-oriented evidence, clinically oriented evidence, and laboratory/disease-oriented evidence, and we tie them together. Over here we've got signs and symptoms, strength, those types of things, clinically based evidence. Those are very lab-based, maybe gait-even analysis, and those are also very important to the clinician, but then we've also got this patient-oriented evidence. Patients don't come in and say, oh, I've got decreased strength, or my range of motion is up. They don't ask about things like that. They want to know when they're going back to play. They're wondering how long their pain is going to be a problem. So when we tie together, and then also clinicians are going to be have some important need or necessity to know about the time frame based prognostics. So I think what we're getting at here is this. This has kind of already been somewhat established, but I think there could be some better work done on it. But really, we're getting at better prediction when we tie those two things together. Questions on any of that? So this is just a model that I created for some of that. Like I said, we are going to analyze some of the NCAA database. We're going to look at things like timing, sport, level of play, even. I think.
You hit the button on the, look at there's a button on the bottom of your pointer.
No, this one's mine. Oh, there it goes. And so, you know, even timing of the season, if the injury happens pre-season, post-season, things like that. We're going to look at some clinical signs and symptoms. We took a look at some tissue damage. This other thing that I'm really interested in is time to re-injury. So what happens after the person goes back? Does the initial return to play affect their time to re-injury? So that's going to be the next step. That was just one example, but I talked about that. We did new versus recurrent grades 1, 2, and 3. We looked at shoulder sprains, new versus recurrent shoulder sprains, concussions, knee sprains, things like that. We're kind of looking across the board. I'm going to jump to the next one, just because like I said, I got to run. The last thing is systematic reviews. And so systematic reviews of really getting at the evidence-based approach to answering a clinical question and integrating the best available research evidence with clinical experience and patient values, and so that best available research evidence, synthesizing that with getting into research evidence-based practice. So systematic reviews and meta-analyses sit at the top of the kind of food chain of clinical research. They're the culmination, the amalgamation of all the research that's out there on one specific piece of information. What they're not. A systematic review is not a literature review. And so literature review is kind of broad scope, it's opinion-based, it's kind of whatever you want to put in a literature review. Systematic review is focused on a very specific question, and it's a comprehensive search and critique of all of the literature that's out there. And it's really a very rigorous process, and usually ends up with a quantitative summary of some sort. So when you look at a systematic review, it looks actually much more like an original research process study as opposed to a literature review, where it's got an introduction, it's got methods that you have to go through, it's got a data analysis section, it's got a data synthesis section, which is a presentation of results, and then you discuss it. And really during this whole data extraction and methods process is where you're looking at every single article that you find on a particular subject, and you're critiquing that article, not only to find out what they found, okay, p-value, blah, blah, blah. You're looking at their means and standard deviations. You're looking at their medians. Then you're also looking at things like how good is that study? What kind of bias was introduced into that study as far as the methodological quality? Were they too open with their criteria? Was there potential bias introduced? I've gone through several of these. This is the first one that I did, but it was, should your patient opt for hyaluronic acid injection and for knee osteoarthritis? And so right away we say, oh, hyaluronic acid, that's like Synvisc, and I know there's like 100 more of them now. And what we found looking at this is, yeah, that sounds like it works. It sounds like it works. Patients report better results. But when you look at all the analysis of the literature, there was actually really no way to recommend or not recommend hyaluronic acid, because a saline injection, when you look at all the literature and critique it, saline injection had pretty much the same result. So basically sticking a needle and squirting something into your knee had similar results as hyaluronic acid. Now, this was a while ago, so if anybody's planning on hyaluronic acid injections, it's probably changed a lot and much better now. But originally, yeah, not much better than saline injection for decreasing pain and patient-oriented outcomes. The other thing is that this was my first one, so it was a little bit more simple. These were some of the, we did go through an exhaustive search and critical analysis, but I think our summary of our results was a little bit less sophisticated than what they've become in the past. I'm not going to go through every single one of these. What I'd like to highlight is a couple of these, like this. I was evaluating neural gliding for carpal tunnel syndrome. Now I'm an athletic trainer. I've never had a whole lot of athletes that had carpal tunnel syndrome. I'm not saying I don't know what it is, but overall, I worked with one of our former doctoral students who was also a certified hand therapist on this particular subject. So me not knowing really too much at all about neurogliding or carpal tunnel, but still I'm able to put together a nice systematic review with somebody who knows a little bit more about that clinical problem. Neurogliding was not clearly effective for all patients, but it's cheap, it's fairly quick, and from a cost and time effective management strategy, seems to improve short-term outcomes. I've even helped analyze things like serum cartilage oligomeric matrix protein, which is a substance that's found in both blood and also in the synovial fluid, this comp, and it has to do with cartilage breakdown. So I've helped people do systematic reviews of whether this particular substance is elevated in patients with NEOA, which it was. I've looked at patient-oriented outcomes and looked at the responsiveness of patient-oriented outcomes. So you get all these knee ones like the Koos or the Lysholm and things like that, and you can summarize the responsiveness based on those. And you can respond, as far as whether those all particularly work. And the IKBC and the Lysholm were the most responsive. So I think the point of those two, all those, is it doesn't have to be something that's specifically in your area, but it's a question you can answer for a clinician of saying, I can put this stuff together and answer a clinical question. These two, I think, will be a little bit more of interest. Di is one of our current doctoral students graduating probably this year, but he put together two systematic reviews on injury prevention programs for ACL tears. And probably one of the biggest things he found is, yeah, they tend to be effective. Some prophylactic benefits to do a neuromuscular training injury prevention program, but compliance is the biggest factor right now. It's not which exercises you do or whose program you're running, but it's compliance is the biggest thing. That they're doing what they're meant to be doing, when they're meant to be doing it at the correct dose is right now the biggest thing. So that was a really kind of interesting thing with all the different programs that are out there that, yep, compliance is the biggest issue. The one thing I just want to bring up for this particular one, we use joint position recognition measurement variables to look at chronic ankle instability. And yeah, joint position recognition, that people with chronic ankle instability do tend to have deficits. But I think we want to highlight that these more recent meta-analyses are becoming more complex, but still are really easy to do. And you can do these in the comfort of your home because it's all computer-based. So it's no searching for subjects and hoping that your subject comes in on time and then they skip and then you have to sit there and you've got all your equipment set up. So that's why I really like doing systematic reviews, because I've had subjects burn me on way too many occasions. So overall, being able to answer a question for a clinician using the systematic reviews, taking actual epidemiological evidence that clinicians are generating and summarizing it into something useful that they can take to their primary clients, which are going to be coaches, athletes, parents. And then also say, can we use the tools that we use in the lab? Can we start to validate or come close to validating, maybe mostly validated, other tools that would be better predictors of injury risk so that clinicians can pick those tools up and use them feasibly? This is really what I'm trying to focus on as far as bridging that gap and not leaving clinicians hanging out there saying, great, you guys are doing all this $1 million research, but it doesn't help me at all, so I'm just going to keep doing what I'm doing. So the big thing with bridging the gap is getting that evidence to the clinician, making sure that fostering research collaborations that can transcend the lab, and that clinical translational research spectrum is really kind of that term that gets thrown out so much, but making sure that with the clinical research actually is something that's feasible for the clinicians. And then the last thing is building clinician scientists. So kind of having them work backwards so that it's not a one-way street. So clinicians saying, okay, yep, I understand this process, I understand how this affects me, let me start generating good evidence. So, collecting good epidemiological data, using these tools, and let me start to give that back to the researchers in a systematic and logical way so that the researchers can do their analysis on it and start to study it better back in the lab. So it's definitely a two-way street. That's it. Thanks, guys. I know that was very fast, but did it on time. So does anybody have any questions? I got a minute or two before I got to sprint.
A quick one. What are your thoughts on Academy on movement screens that, like FMS comes to mind, that it's strength and conditioning practitioners are kind of using, so outside of the clinical field per se?
So the FMS, one of my favorite ones right now.
Oh, yeah.
We've had, and I was just in Indiana 2 weeks ago talking to some master's students, and a couple of them were studying the FMS there too. So we've run several studies on the FMS recently in the last couple of years here at UK, and then with the football teams and track, and I forget what else. And then, but one of the major problems is that the way that it's scored, it's not very good at predicting injuries. That 14 cutoff wasn't that great, but also from just an overall injury predictive standpoint, it wasn't that good. Also, there was a couple of other issues with it as far as the specificity of those, the way that it scored, the 0, 1, 2, 3, blah, blah, blah. There's some issues with that. But here's what's interesting. We had one of our students presented the other day, just in class for fun, and she was showing videos of one of the students, one of our other students, and she was doing all the different things. And if you looked overall at that girl's scores, we all scored them. She had all like 2s and 3s, and you say, oh yeah, that person's okay. They're not going to get injured. But if you looked at her movement was all over the place, but she didn't score poorly on the thing. So what I would say is also the other thing that I saw is whenever she went to move her distal, her proximal was all over the place. Like she didn't have a stabilized move kind of thing. It was like every time, and then she would get there and then stabilize. So it was this distal proximal motion, and so you say, all right, she scored fine, but looking at the videos and using those movement techniques, she's not okay. And probably if I was going to focus on her, I wouldn't have her do like just planks or anything like that. And I would definitely have her doing some stability with movement type of training of some sort, because that's where she was a mess. So the scoring, I don't know, but the actual movements themselves, the functional movements, especially the way that she filmed them, and even if you were just looking at somebody in real life, I think you could identify deficits and make adjustments, just not base it on the scores. That's what I thought of that one in particular. Anybody else? All right. Thank you. Thank you.